This is my journey. Inspired one story at a time, a library of leaders was created. It began as a journey to learn. As time went on, it began to grow. All it needed was a platform, and this podcast was created to listen, to inspire, to share. I am a storyteller, and this is my journey. Welcome to another episode of Profiles in Leadership. I'm your host, Steve Anderson, and this episode is brought to you by Silna Health. That's S-I-L-N-A, the premium front-end RCM company that leverages technology with a team of onshore insurance experts to handle benefit checks, eligibility checks, and prior authorizations. Finally, a vendor that you can trust, like a full-time employee that scales with your business. Just mention the Profiles in Leadership podcast to receive a free trial. Today, our guest is Michael Johnson, PhD, PT, and he is a chief researcher with home care innovation at BAYADA Home Health Care in Moorestown, New Jersey. This is a new role for Dr. Johnson, and he is responsible for building an infrastructure that will support collaborative research efforts across 8 specialty practices in BAYADA, partnering with academic researchers, industry leaders, as well as payors and policymakers to advance the quality and accessibility of care in the home. Prior to his role as chief researcher, Dr. Johnson spent nearly 10 years as president of Home Health Practice, which is comprised of over 120 offices in 22 states that provide care to nearly 29,000 clients weekly through a multidisciplinary team approach delivered by over 3,500 clinicians and staff. The practice focuses primarily on geriatric home care services under the Medicare Program. He also served concurrently as president of Hospice Practice for 3 years, which is comprised of over 20 offices in 8 states that provide end-of-life care to nearly 1,400 clients daily. He has also served in multiple elected and appointed roles within the American Physical Therapy Association over the past 30 years, including as a member of the Scientific Advisory Panel for the Center on Health Services Training and Research, otherwise known as CoHSTAR. He lives just outside of Philadelphia, Pennsylvania with his family, spouse of 33 years, Beth, and their 3 adult children. He holds a BS in Physical Therapy from Northeastern University in Boston and an MS in Orthopedic Physical Therapy from MCP Hahnemann University in Philadelphia and a PhD in Health Policy from the University of Sciences in Philadelphia. So, Michael, welcome to the program. It's great to have you on today. Thanks for your time.
Great. Well, thanks for the invitation. I'm glad to be here. Looking forward to the discussion.
So let's just start with a little context here. We heard about kind of where you went to school, but where did you grow up, and what got you interested in physical therapy, and just give us a little background information before we get rolling here.
Yeah. So I haven't dug into the treasure troves of right where I grew up, but I'll give you a little bit of the. I grew up mostly in Pennsylvania. My parents, for various reasons, moved a bit. So between kindergarten and 12th grade, I went to 8 different schools.
Oh,
and
wow.
I share that because I think one of the things that I learned from that was how to connect with people very quickly. It was sort of a survival mechanism. Have 4 brothers and sisters, so the 5 of us are very close in part because we were each other's only friends every time we moved to a new neighborhood, but met lots of nice people. And ended up graduating from Honesdale High School, which is in the northeasternmost county of Pennsylvania. Most of my family is still there, my father, brother, sister, and so forth. And I got interested in physical therapy because my mother was a nurse. And in fact, one of our moves was from Honesdale out to Pittsburgh for 2 years when I was very young, because my mother got a grant to be funded to take what was the first diploma, not even diploma, certificate for a nurse practitioner. My mother was actually one of the very first nurse practitioners in the entire state of Pennsylvania. I joked that her license number was like 0007. I'm not sure she was that early, but she was really a pioneer before the nurse practitioner role turned into what we know it today.
Yeah.
So it was that was my sort of introduction to healthcare. A lot of our family friends were in healthcare, physicians, nurses, and so forth. But I was athletic and in school, and so the idea of physical therapy and rehab was appealing, and that's sort of the path that took me in that direction.
Okay, interesting. So why, you go to physical therapy school and then do you go right into the home health world? Do you take some positions ahead of that? How did you end up in, because you focus mainly on home health the last
Yeah.
few decades?
So when I graduated from PT school, and you and I are of a similar age, I graduated with a bachelor's degree, right? Those haven't existed for a long time,
Right.
and I still can practice, much maybe to people's surprise. Uh,
Yeah.
but when I graduated from PT school, it was at a time, it was in 1990. I went to Northeastern University undergraduate, which was at the time was a 5-year co-op program, which was great in terms of the experience that you got. But there was such a need for physical therapists at that point in time. My hometown hospital reached out and offered to pay my tuition for my last year of PT school if I would commit to coming to work for them for a year.
Okay.
And my response was, "Let me think, yes."
Yeah, right.
That was it was at the time it was something in the $7,000 or $8,000 range. That was a lot of money to
Yeah.
me, and so I went and worked in my hometown hospital for the first year. Probably would have stayed longer had they required 2 or 3 years, but I actually had met my wife in my last year of PT school. She lived in Philadelphia, and that's how I ended up transitioning down to Philadelphia.
Okay.
Um, and so when I came to Philadelphia, I was looking for a job that would give me sort of broad opportunities. I was primarily outpatient in my hometown hospital. I wasn't opposed to outpatient, but I was actually really interested in rehabilitation, stroke, amputee, that sort of thing.
Uh-huh.
And so I couldn't, but I was looking for some variety. So I actually found a position that was 20 hours a week in a sports medicine clinic and 20 hours a week doing home health,
Oh, wow. Okay.
which was unusual. And that's how I got, because I figured home health would give me some experience with rehabilitation, and then I knew I had done a year of orthopedics, so I'd have a comfort level with that population. And it turns out, as excited as I was about the idea of sports medicine and working with the Eagles and all that stuff, I actually really liked working with the older folks in their home because,
Yeah.
let's be honest, if a football player misses a game, it's not the end of your life. But
Right.
if an elderly person can't get up the stairs to use the only bathroom in the house, that's a big problem.
Yeah.
And
Yeah.
so it was much more fulfilling for me and I fell in love with the geriatric population.
Really interesting. So tell us about BAYADA. Am I saying that right? BAYADA
Mhm.
Health. And what is that organization? What does it do? And you've been with them for quite a long time now. So tell us about your roles in that organization.
Yeah, so I came to Bayada 16 years ago. Bayada is a family-owned business. Um, the founder's name is Mark Bayada. His last name is spelled with an I. The company is with a Y. It's spelled sort of phonetically. And we just celebrated our 50th anniversary.
Wow.
I came to the organization at a time where they were getting ready to make a move towards some reorganization because we have a mission statement and a vision statement called the Bayada Way. Many organizations have those. What I like about this organization is we actually pay a lot of attention to it. And one of the things it says in that document is, it's compassion, excellence, and reliability are our core values. But it says we're going to be here in 100 years. And so if you really mean that you're going to be here in 100 years delivering good service, you have to be thoughtful, take your time, make decisions that are longer term, that aren't necessarily quarterly earnings pieces, which you run into in the public sector. And so at that point in time, they had made the determination that um, the offices that provided services provided multiple services. So there may be an office in Willow Grove, Pennsylvania, one of our first offices just north of Philadelphia, and they would offer private duty home health aid services. They would offer Medicare certified services. They would offer long-term high-tech skilled pediatric services, all out of that same office. When I
Okay.
came to Bayada, they had made a decision that we needed to get the practice lines needed to be more specific. Get good at one thing. Don't try to do everything, or we're probably going to not get good at anything. And so
Yeah.
we've started that journey 16 years ago. And we now have 8 specialty. We call them practices, call them business lines. And I've been part of the home health practice from its inception. But we've got hospice, we have high tech pediatric adult services, so folks paralyzed, Lou Gehrig's disease, some of these things where we keep people safe at home so they don't have to be in a facility. High-tech skilled pediatrics, hospice, behavioral health, autism services, and so forth. So we just, from a revenue perspective, annualized revenue for this past year, we hit a record. We passed the $2 billion mark, which is a good indication that we're taking care of people. The dollars are, to me, less important than the people. And we're sort of on a path to, we've got these 8 practices stood up now. How do you interact with one another? We're trying to build systems of care. How do we make sure a home health patient gets to hospice when it's appropriate? Those sorts of things. So it's been a fun and very interesting journey from a leadership perspective.
So Bayada, then you would probably say, is a legacy type company. So, they want to be in it for the long haul. It's a legacy approach. So is it funded by outside financial sources as well, or is it all done internally through provider payments? What keeps it going with that kind of revenue? That's huge.
Yeah, it is. There is no there's no external funding.
Okay.
We basically live within our means and have for 50 years. But
Yeah.
one of the things that the founder and the family made a decision to do 5 years ago, from 2018 to 2019, was that tax-wise, it was considered a for-profit organization, a family-run business.
Hmm.
They actually made the decision to transition the company to a non-for-profit,
Oh, wow.
which
Okay.
is really, it was probably, at that point in time, top line revenue was probably 1.3 billion, right? No small change. And similar home health companies were selling for 1 to 2 time multiples of the revenue. So another way to put that is the owner gave away over $1 billion because you have to donate the company to a non-for-profit. And they spent 10 years trying to make this decision, but it goes back to the mission, which is, if we're going to be here in 100 years, what he identified was in the US, and it's not good or bad, it just is how our capitalistic society is set up, is most family-owned businesses do not survive the 3rd generation.
Yeah, that's
Right.
true.
Right. And not because the 3rd generation is, greedy and so forth. They just have different passions. And so very often they'll sell the company and invest in something else that's meaningful.
Yeah.
But Mark wanted to make sure that the company was there. And so the reason I share that is we now are, one of the other reasons for doing that was it allows us to do philanthropy and helps us do some fundraising to cover the cost of some of the services that we weren't able to provide before, because we are primarily dependent on government funding, Medicare, Medicaid, and then some private pay in our private duty service line.
Yeah, that's amazing. So is Mark still around?
He is. He
Is he
is.
still
He
in the
is.
business?
Yeah, he's 77, I think now, and as sharp as a tack. He
Wow.
is the board of directors. He is the chairman of the board for the non-for-profit. And his son David, who hired me, David is the CEO of the corporation that runs the business, and then we sit under the larger entity of the non-for-profit.
Okay, so when we looked in the bio, you had managed some large departments, so to speak, or business
Mhm.
lines, as you call them, which involve a lot of people. But you also are, identify as a researcher and do researcher. So, are you a
Yeah.
researcher? Are you a leader? Or are you both?
It's a good question because people are like, those two things can't coexist.
Well, they're a little out on the opposite ends of the spectrum usually, but not always. So,
That's right. Well, they certainly. So I have either the unique ability or the definitive flaw that I'm curious by nature, but I like to get things done.
yeah.
And it's not that, and so I'm both. Let me answer your question. Uh, I went into PT, as I mentioned to you, because my mother was a nurse, and I was exposed to the impact you can make on people's lives through healthcare. My father, on the other hand, was a teacher, and so I was interested in teaching. So after being in clinical practice for about 5 years, I had an opportunity that was unexpected to join a faculty in Philadelphia, and ended up going on a 10-year journey in the academic setting.
Okay.
And got my master's in orthopedics, which was really biomechanics. And I was going to get my PhD in biomechanics because I thought that's the direction I was going to go. And you'll remember that was right around the time the Balanced Budget Act of 1997 kicked in
Yeah.
1999.
Yeah.
And for folks that don't remember that, hospitals, as I described earlier, were throwing money at therapists to come work for them, right? My hometown hospital did. June of 1999, half the class that graduated from Hahnemann University couldn't find a job.
Yeah, I remember those days.
I
Yeah.
remember that. That was a wake-up call for the association and for the profession. It did a number of things. It created the Government Affairs Committee, which things that we
Yeah.
didn't have in place before. Um, uh, but I mentioned that because, excuse me, it caused me to say, I'm not getting a PhD in biomechanics. If a bunch of people who don't understand anything about what I do as a physical therapist can make decisions that impact my ability to take care of patients, I got to figure out how that works.
Yeah.
And that's when I made the pivot to getting my PhD in health policy. And so I was on a research track and so forth. But I eventually left that because I felt like I was too far away from the action.
Okay.
And so
Yeah.
I consider myself a bit pragmatic. So I'm a health services researcher, but I'm also an operator. And I think you need to be both.
So going back to being president of the home health practice side, I think there were like 3,500 employees in
Mhm.
22 different states. How does somebody lead that? How does somebody, if I were to say, what's your leadership style to those people, what would they tell me? And how do you keep everybody engaged with that many and that geography?
It's a great question. And I will tell you the answer to that question, I did not learn in PT school.
I'm sure you didn't.
That is one that you figure out as you go. And so, I was lucky I'd had lots of bosses that had great leadership skills. And so you start to say, here's my picture of what good looks like. And here's what I would want if I were a clinician practicing at BAYADA. And here's what I think I'm good at. And so my leadership style was I'm a people first kind of personality. I'm
Yeah.
more of an extrovert. You can probably already just tell that. And so what I wanted to do is I really and the academic in me wanted to help people make sure they understood what we were doing and why we were doing it. So there were several things that I did to make sure that people felt like they were connected to something bigger themselves. So first thing, I got advice that you should have um, a mission and a vision for the practice.
Mhm.
So very quickly, I worked with folks, got a little bit of feedback, and created the mission that we're still driving to today. Is I said we were going to be the Mayo Clinic of home health care, and I picked Mayo because I think anybody who thinks of Mayo or Cleveland, it could have been the Cleveland Clinic of home health care, but some of those really well-established institutions, that it was an indication we're going to be the best there can be.
Yeah.
We're going to do that by doing two things: reducing variation and improving our performance. And that became sort of a rallying cry. And I use it for anything I talked about. I talked about how this is going to help us become the Mayo Clinic, how it's going to help us drive down variation, because then at least you anchored what you were doing to something that resonated for folks. Um, and then the other thing I will add that I think was two other things that were successful is I got out and made sure people knew who I was,
Hmm.
because my perception when I was going into the role was an organization where somebody's running a $500 million business with 29,000 patients. This is just a button pusher who's completely out of touch with clinical practice, and he's going to make bad decisions. Right? I
Yeah.
didn't want to be that guy. So
Yeah.
I made a commitment to go out and visit offices, every office every year. I never got to every one of them in a year, but I would through a 2-year process, and I would sit with everybody in the office and the field staff and just have an open town hall and a forum, give me good insights. I could share what I was thinking. And then I did a 5 to 7 minute video every month for 7 years that just
Wow.
said, hey, here's what's going on in the practice. I would recognize people, and just people want to feel connected. And so that was those things, and then building a system of sort of meetings and structures where we could actually continue to get good work done. It was a really interesting 10 years of doing that. So that's the short and skinny.
Well, that's leadership 101. I mean, explain the why, keep people engaged. You chose what I would call as you said, people first or people asset approach, which means you got to be boots on the ground. You got to be seen. People have to know who you are. And that takes a lot of travel and it takes a lot of time. And,
Yeah.
it's my approach as well. That's what I prided myself in doing when I was in a leadership role like that. But, there's some sacrifices involved. You're gone from home a lot. You're on a plane a lot. It takes time, but I do think that the more you know them and the more they know you, I think the better you can work together as a team.
Yeah, I agree. The other piece with the mission is we had just expanded our measurement criteria for what good looks like. We had 4 pillars. If anybody's familiar with Quinn Studer's work around excellence, people that are in the healthcare hospital systems are maybe familiar with, but he had a 5-pillar system. And when I stepped into the president's role in 2015, we expanded our 4 pillars to include the 5, which are people, service, and that's sort of customer service, quality, growth, and finance. And one of the things that I coined to help people understand how we approach this was we lean left, people, service, and quality. If you have the best people, you have the best experience for your clients or patients, we call them clients, and they get really good outcomes, then you're going to be obligated to grow because everybody's going to want your services.
Right.
And then if you manage the pennies enough to have dollars left over to reinvest, but so this concept of lean left and look right is really how we approach it. And I continue to approach it because there's a lot of organizations that come across very much as if they want to lean right. I'll make a ton of money, and once I do, everybody will be good. And maybe that happens, and maybe it doesn't.
Yeah, interesting. So yeah, we said in the bio that you have a new job now, which is a chief researcher. And
Mm-hmm.
so tell us what that role is like, how it's different from what you're doing before. And then my question too is are you actually doing the research or are you just managing the team that's doing the research?
Yeah. So I'll start answering that last question by saying the research department, or whatever we're calling it here at BAYADA, has 1 employee, and you're looking at them.
Okay.
So it may grow into more than that, but I was pretty adamant that there's enough resources in the world to do research. Lots of university settings, at least 1 home health agency, the Visiting Nurses Service, VNS Health, has a research component. But for the most part, that's not something that we do. We're taking care of people. We're running the business, but we need answers to questions, especially now that we've got more and more data. So in this new role, it was offered as part of for non-for-profit. Let's go back to what I said before, the Mayo Clinic of Home Health Care. When I think of Mayo, you think of clinical excellence. So we want to try to do that. Mayo has a medical school, so there's an educational component. We're educating our own nurses at BAYADA. And then Mayo, what most people know is Mayo is known for their research efforts. And so adding that research effort was another move in my mind of being sort of more like a Mayo-like organization. So when that position got created, they offered it to me, and I actually thought about it a little bit, but not too long before I said yes. It gave me a chance to start to focus on building the evidence base to convince payers why there's value in what we do, and there's not enough time, energy, and focus to do that when you're running the business. And it was a nice new challenge. So we are really focused around 3 quick things. One is, how do I help the existing businesses accelerate, grow, and be successful, right? So it's still about driving the business, which is taking care of people. Number 2, how do I help build relationships with research organizations where we can answer questions, they can help us answer questions we both have together. And then 3rd, how do I help connect this broader research network across home health so we can help the industry? That's sort of how I'm thinking about it.
So let me get this straight. You went from managing 3,500 people to managing no one.
Right.
That's that's not a typical career path. That's not normal.
No, it's
So it's
definitely not.
almost like I'm just sitting here trying to say, "Wow, you must have got up one morning and said, my job is dramatically different here." That's a big change, and so I think you kind of answered it a little bit. But my question is, why? Is it just too hard to sustain what you were doing before, and you needed something different, or did you just have something unique, a unique talent or gift that the leadership in BAYADA said, "Here's the guy to do this"?
It's a good question. I didn't leave the home health practice because I was unhappy there. The stressors, as anybody, and you know this, Steve, really well. When you're running a business, let's be honest, the business runs you,
Yeah,
right? In some ways. And so,
yeah,
some people derive a lot of energy from that. I did for a long time. The pandemic sort of beat a bit of that enthusiasm out of most of us,
yeah.
but I wasn't running away from anything necessarily. I, for the longest time, have had this vision in my head that healthcare should work for everybody. Now, let's not confuse that with it should be free. And like, I don't know the answer to that question, but it should work better for everybody. We really should have a healthcare system that makes it easy for people to navigate. We are far from that. And
Yeah.
so I've always kept that in mind. And so when I left the academic setting, after being there in 10 years, first of all, my colleagues couldn't believe it. I was on a tenure track position and nobody walks away. Like this is, well, I guess not. That's not always true because I wanted to get back closer to the action. This is around the mid 2000s when we were just starting value-based purchasing. This whole concept was coming into play, and I thought that would help, improve the healthcare system. And I came to BAYADA to basically make sure I understood how to run a business because the reality is that is part of it, and you've got to be able to run a healthy business if you're going to deliver services. So I think I feel really good that I helped do that. We've been very successful as a practice. And now this opportunity to step back with the context that I have of running a business and say, how do I help fill gaps, partner so we can actually build an evidence base to advocate for the work that we do in home health was a challenge I couldn't pass up because the last thing I'll mention is hospitals and physicians get all the attention.
Yeah.
They get all the dollars. Home health is a tremendous value. People are in the house by themselves at great risk sometimes and do amazing work, but don't get recognized. And so I'm like, okay, how do I help shed some light on that? And I felt like taking this role, I'm working across all of our 8 practices. So it's helping me, I'm learning new things, which is fun. But in the home health practice, it's helping me spend time building the case for stuff I tried to argue for a decade.
It almost sounds like you had like 3 or 4 different careers.
It feels that way, Steve.
Yeah, I can imagine. So when you think about, who you are, do you identify as a relationship builder or do you identify as a scientist?
Again, I'm gonna take the easy path, where I think that it's both. I don't think it's either or. What
Okay.
I really like to do is build bridges.
Yeah.
Right. I'm convinced, and have been for a long time, that a multidisciplinary approach to solving problems is going to work better. And so in health, it's part of the reason I came back. I went to BAYADA as well as I love physical therapy. I love physical therapy. And as you mentioned in the bios, have been very active in the association, state association, was chief delegate, very, very committed to my profession. But physical therapists can't do everything.
Yeah.
Right? You need a nurse as a partner. You need an OT as a partner. And so I like that multidisciplinary. So I use that as an example to say, I think you need, if you're going to build a business and you're going to help build the system, you really have to be thinking from multiple angles. So you've got to understand the business side of it. So I'm an operator and a proud operator, but you've got to think about it from the strategy side, so strategy, and then the research piece, which is, I just call it is unending curiosity and a level of determinism and maybe grit to get to the answers of the questions that you have and be willing to accept those answers and make adjustments, especially when they're not what you thought they were going to be, the answers it is.
Yeah, it's really, really interesting. And when you look at, I know that you said that BAYADA doesn't necessarily use grants to fund, fund its operations but a lot of the research that you're doing is funded by grants. And I mean, I don't want to make this political, but in a world where that world is under fire right now and questions about whether we should be spending money doing that or whatever, how does that affect your business and how does that affect your company? Is there concern there?
Yeah, there's definitely concern, and irrespective of where people sit on the political spectrum, what's being done, and more importantly, how it's being done is concerning to me, because research is the bedrock of it's one of the things that this country is so well known for, particularly medical or healthcare related research. So, we don't know what's going to happen to NIH funding. But one of the things that, and this, again, it's part of the reason I stepped away from the operations role to this research role. One of the things that we have that researchers want and can't get access to any other way is we have data, right? They can use Medicare claims data, but claims data doesn't have the detailed information of the visit what happened in the visit, right? How long was the visit? Things that I refer to as sort of dosage. And so there's a one of the very first sort of official research partnerships that I helped develop was through the CoHSTAR Institute, and then it's the follow-up organization called Learn, which is rehab research, was with a PT at the University of Washington that we're still working with. We looked at the difference between utilization and outcomes for people who had traditional Medicare and Medicare Advantage. And that paper got published in JAMA about a year and a half ago and was one of the top 10 most read articles in 2024. And why am I proud of that? Because it got the conversation going about care in the home and the differences. And so, excuse me. And so I think that making sure we're there to answer those questions and doing it goes back to partnership. I think we can still do that because our data will help. We may be able to do some fundraising for grant work, but it's going to be interesting. But we've got the partnerships. I think is just as important as the dollars, and that's what I've been working on building.
Well, without going into too much detail, for those who haven't read that report that you just referenced, what did it say in a nutshell?
So in a nutshell, what it said was folks that have traditional Medicare versus folks that have Medicare Advantage. Well, first of all, the two populations are more similar than not. So you would expect their needs would be similar. But folks who have Medicare Advantage got significantly fewer visits, got fewer visits by nurses, by therapists, and by home health aides, had shorter lengths of stay. Finally, they were more likely to be discharged back into the community versus into a facility, which could be a good thing. But the question we had was discharge into a community where you don't necessarily have resources. And actually, final piece, and this is the PT in me found this really interesting. They had worse functional. They didn't improve on their function as much as somebody who had traditional Medicare, and maybe begin because they had fewer visits and a shorter length of stay. So it's almost as if they didn't get tuned up quite as much as if folks on Medicare did. And I think that's my hypothesis that in part has to do with the structure in terms of how Medicare Advantage pays for services and the regulatory and administrative scrutiny that they put home health agencies under. So it's not so much how much you get paid matters because you got to pay your staff. The payment model also matters is what I walked away. And Medicare Advantage, their model is very different than traditional Medicare.
Okay, so I think the underline, maybe we're not coming right out and saying it, but this is about profit and not for profit, right? Medicare Advantage is a profit-driven system, and regular Medicare is a government-funded nonprofit situation. So basically, what you're saying is that more money into the system, or just because people that are making money on the healthcare system, doesn't mean that they're getting better care.
Correct. There's a growing body of evidence to say that there are clear differences between how in home health, but in other settings, Medicare Advantage versus traditional Medicare. There are differences, and it comes back to whether it's for-profit or non-for-profit, but it's payment model. We did to sort of reinforce that. We just got our second paper from that project accepted into the American Journal of Managed Care, which will come out in November of 2025. And what we did was we said, okay, traditional Medicare, Medicare Advantage, there's a difference. I just described that difference. But Medicare Advantage pays providers differently. Some pay them per episode. So there's an episodic payment, and some pay fee for service, like per visit. And so we said, okay, is there a difference between traditional Medicare, Medicare Advantage, fee for service, and Medicare Advantage episodic? And the answer is there is. For folks that have managed Medicare, fee for service, they are much more likely to have some sort of an adverse event like a hospitalization compared to either of the other two groups. And so the outcomes aren't as good.
Yeah, well, I don't want to put, words in your mouth here or whatever, but kind of my next thought is, what are the challenges that BAYADA sees going forward? Is it related to this tug and pull of these, for-profit, non-for-profit government agencies, so on, or is it more from the provider side of just finding enough people to do the work that's required in our world?
I'd say it's a little bit of both, and I'll come to the provider side in workforce because I think there's an answer there that we should really be thinking a lot about. From the payer side, part of the reason we're doing this research is not to tell the Medicare Advantage organizations how awful they are, but I firmly believe that in most cases, maybe not all, but in most cases, they're trying as well to take good care of people. They're trying to do it as inexpensively as they can. I get that. And so we're using this research to go and say, hey, we think we can get you the outcomes you want. Reduce readmissions because they have to pay for that, right? Better patient satisfaction. But our research suggests the way to do that is for you to pay us episodically, put us at risk, give us targets, and it changes the game. And so we have actually 80% of our contracts right now are more episodic than they are fee for service. So we're having some success. So how do we both win? So I think it's driving that conversation. The other is if you've leaned left with people, service, and quality and done a really good job, people are going to want your services. Well, if they want your services, you need more PTs and nurses and so forth. And so that challenge is only getting more difficult. I think for us, one of the top priorities is how do you use technology to unburden clinicians? Whether it's ambient listening technology, there's a whole bunch of we're right on the precipice, quite frankly, I think, of that. And if we can do that, if we can unburden the clinician, because there is so much documentation in healthcare and in home health, particularly if anybody knows anything about the OASIS,
Yeah.
it is the most onerous assessment document in the world.
Oh, gosh.
And I challenge anybody, if somebody has a better example, I'd love to see it. But my point with that is it takes 2.5 hours to do a start of care. Most of that 2.5 hours isn't face-to-face with the patient making a difference. It's some administrative documentation to prove that you deserve the payment, whatever. If we can help the clinician do that more seamlessly through artificial intelligence, and they can actually spend more time with the patient listening, it's a game changer. We will open up workforce capacity without hiring a single person, and I believe our clinicians will be much more happy in the job that they're doing. You and I didn't go to PT school to push pencils.
Right. Well, in the outpatient world, they are making some inroads on that, and some of the new AI tools coming out are good, and they are finally saving time. I mean, you and I have heard for 30 years that if you do this,
Yeah.
you save time, and it never did. But
Yep.
I think it's actually working, this time. And then I can remember too, I don't have any experience in home health, but I do remember as a practicing physical therapist, well, home health is cool, but the paperwork is brutal, so you don't want to do that.
Yeah.
So I'm sure not only trying to find PTs in a setting like home health, because not everybody wants to do that, and then the burden of the documentation on top of it is a double whammy. So I'm sure you're thrilled that if you can decrease that amount of time of the report, it'll make a huge difference.
Yeah. I have great faith that it's finally going to get there. But you and I have been disappointed over the years because you remember, Steve,
Yeah,
EHRs were supposed to be going to save us a ton of time. They did exactly the opposite.
yeah, yeah,
Right. But I do think, and I saw an example at a conference I was at recently of AI technology that actually will listen to the conversation, put it right into the Oasis. We're getting close now. Data privacy and so forth is an issue, but if we can get a nurse or a therapist to spend 30% less time on documentation, but then turn that into a little more time with each patient you have, maybe even seeing an additional patient or two, I think they would do that trade-off all day long.
yeah, absolutely, absolutely. So, when you talk about AI, again, there's so many aspects of it or whatever, but as things just come up. Maybe I'm not in it like you are as much, but I just saw something the other day where, somebody can take an outline of a proposal,
Mhm.
put it into Chat GPT, and have it come back as like you and I being on a podcast right now discussing the proposal, and as a way to present it to your people, here's what we're doing. And it was brilliant, to be honest with you. It was like, oh my gosh, this is unbelievable, because somebody might the reading the document and the outline, and the way it's always been done may resonate with them well, but somebody else who doesn't learn or doesn't see that in that same way. Hearing it in like a back and forth discussion between two people on a podcast might get the
Yep.
message, and it's just so yeah, I think there's some really exciting things on the AI front, and especially if it can save time and take away the burden, because that's just miserable in healthcare, and we all know it.
It is. I think one of the things I would encourage folks, um, that I think is going to be even more important with AI is that we all become a little bit more, I won't say researcher. The word I would use is we all need to make sure that we become better scientists,
Yeah.
right? And why do I say, and so you could use researcher, but really what I am is I'm a scientist. And a scientist is curious, but also disciplined. If you think about the scientific method, and why do I say that? As I've used AI, you're right. Some of the stuff it comes up with is unbelievable, but we shouldn't trust it 100%. So my philosophy is it's a really, really good first draft. And then you've got to go through it with a bit of detail to make sure that the citations are correct and ask. Well, I say we need to make sure we stay and even ramp up our scientific perspective is dig into that and ask a whole bunch of whys. And that good start will turn into something really, really good. But if you take it on face value, just what they print out, actually, I think we're going to be in trouble because it is far from perfect, but it's pretty darn exciting stuff.
Well, it's gotten so much better. I mean, we can remember the days when we might decide we're going to talk into our iPhone to Siri for a text message, and it comes back and say, "I didn't say that. Where did that
That's right. Yeah, she booked you flights to Japan. Like, where'd that come from? I was asking for cheesesteaks.
say?" Yeah, exactly. So, Michael, are you still involved in APTA, American Physical Therapy Association? You still doing things for them, or have you kind of gone on to the bigger picture with in healthcare in general at this point?
Well, I have not done as much with my state or national association for quite a few years, and primarily because I literally did not have the time. I think you, Steve, may have invited me to the Graham sessions one point in time,
Yeah,
which I really appreciated
absolutely.
because I
Yeah,
missed
you
that.
are.
I missed that brotherhood and sisterhood.
Yeah,
So I am in this new role. I've got more. My schedule is a little bit different, and so actually I saw Justin Moore not too long ago. I was down at APTA headquarters for a meeting, first time that I'd seen the new headquarters, and I just
yeah,
said, "Hey, if you need any help with small like whatever, I can." So I'm hoping to get back in some way.
yeah,
But what I will say to folks that are listening is the countless hundreds and thousands of hours that I donated to service to the association, whether it was at a district chair in Philadelphia or as the state legislative chair for Pennsylvania or as the chief delegate around the Government Affairs Committee, that was those experiences in APTA and PPTA at the time prepared me for the work that I did at BAYADA in ways I never would have expected in terms of managing people and running meetings. And so don't there's value in service that you might not appreciate. So I'd encourage folks, if you're not involved, get involved.
yeah, for sure. And that building is amazing, isn't it? I
Oh yeah,
mean,
it is.
did such a good job. And you think back in the days when you were active and you were at the old building, and the stark differences between the two. Not that it's all about what you see, but just the impression and the functionality and the
Yeah.
collaborative atmosphere and whatever. It just gives you a whole different feel of what can be done.
Yeah. Well, and that goes to the wisdom of our forebears in the profession. I can't remember if it was Marilyn Moffat or something. Like
Yeah.
the person who decided to buy rather than rent those buildings in Alexandria that we eventually sold. I mean, that was huge because those became worth so much. It funded the next one. And so a lot of thanks to some of our forebears who made really good financial decisions so we could have an amazing building, for example.
Yeah, I agree totally. Well said. So let me ask you this. You're in this, geriatric world more so than say others, and you understand it well. What do you think about the explosion of these senior living facilities? It's kind of like it seems like everywhere you go now, there's a big new complex going up that are, everything from independent living to assisted living to memory care and whatever. Um, do you have a feel is that helping that elderly population and living lives more fulfilling and healthier, or not? I mean, or do you think we should do more in the home?
It's a good question. You're asking somebody who's clearly biased to the home, but I will say a full third of our business for the practice is delivering home health services, primarily Part A. We do deliver Part B services, or we bill under Part B for services as well as fitness and wellness. A full third of our business is provided in congregate living settings, independent living, assisted living, memory care. So it's a big part of the business. Whether it's good or not so good, I think there's a couple things that I think about. Personally, my mother developed very slowly and then very quickly progressive dementia. And so it took us a while to figure out what was going on because things just didn't add up. And why do I say that? Because she lived about 2 hours away. But we wanted to keep her in that community because that's the folks she knew. We were able to find a senior living community that could give her the support she needed, that we couldn't from Philadelphia because I couldn't relocate. And eventually she ended up needing memory care. They had a memory care unit. And then eventually, as she declined, they moved her into a nursing home that was part of that organization. And so I say that to say it was incredibly helpful to have those as I was the power of attorney, as the
Yeah.
son of a mother who was in this just awful decline. Anybody who's
Yeah.
ever dealt with it, it's there's just no other way to describe it. But so there is a place for those that now could we have moved her into our home? Potentially. But
Yeah.
I think that's where it can be very helpful. I think it can also be helpful in terms of helping keep folks active with folks that are of a similar age. But I think I worry a little bit about there is value to go back to a comment I made earlier about multidisciplinary. In this case, I'm going to make up a word here, multi-age-ary, right? When you live in your home, the neighbors are young with two young kids, and you're the older person in the neighborhood, and like you can help. Just the experience, the variety that you get when you live in, or the lack of variety that you get when you're in a senior living community that's 55 or older or 65 and older. I do
Yeah.
worry whether we're missing out on the wisdom that the elderly can provide, and at worst we get suggesting that we're warehousing our elderly. So it has some good stuff in some other places where maybe we're missing opportunity.
Well, and you're as a researcher, you too look at comparisons. So when you look at the cost it takes to put someone, well, that's a bad term, to have someone in a facility
Yeah.
like that, your monthly fee is expensive.
Yes.
You well know. And then you could also say offset that by just bringing services into the home, and you take that same amount of money. Do you have a feel? Is it more cost effective to keep the person at home as long as possible, or do you think in the long run, can you compare the two?
Yeah, it's a really great question. Part of it depends on how much that person can do for themselves. So, for example, my in-laws. My father-in-law is 88. My mother-in-law is 85. My father-in-law is cognitively pretty much fully intact, but moving real slow. Physically, he struggles. My mother-in-law is moving just fine, but cognitively, she's on a fast decline. They're living together in the home that my wife grew up in, and we are in the process. We just hired BAYADA to provide home health aid services during the day to help with things like meals, medication reminders, and so forth. But they don't need to be there at night.
Yeah.
So in a
Okay.
case like that, if we're augmenting some services, take my mother-in-law for a walk, make sure she's safe, help her with the medication, and help my father-in-law with meals, I think it's a much more cost-effective route to go.
Mhm.
And the person's you're still in your surroundings, you're in your home and so forth. If there's a point, and this is the point that my mother hit, where she needed basically somebody that was always keeping an eye on her because we couldn't trust that she was going to leave the stove on or whatever. That's
Right.
where it becomes for 24-hour service, even for a home health aide. I think in most cases that starts to exceed what it would cost you to put them into a senior living community. And so
Yeah.
you just have to sort of weigh how much support do they need and balance it that way.
And they also need a place, whatever the home is, that makes sense. I mean, there's a lot of homes that, are fall risk disaster zones, and they just
True.
stairs and whatever, so you have to have a place that's functionally going to work for that as well. But yeah, I mean, everybody wants to stay in their home,
Sure.
so if you can make that work, it certainly makes a lot of sense.
Well, and I think that's we're spending a bit of time. And again, you could call it self-serving, but I think most people, particularly the generation that's turning 65 now, has very different expectations of what retirement looks like than the generation that turned 65 20 years ago. And
For sure.
I'm not there yet, but I'm bumping up close to it. I'm about 6 or 7 years away, and I have a very different picture of what a retirement and active lifestyle looks like. And so it'll be interesting to, I think there's going to be more and more pressure from the public to stay home. And so this is where technology can be helpful, right? Because you can have fall sensors, and so you don't have to be there all the whole time, but you could be there quickly if something happened. Um, and that's where the technology is going to have to become a key component, because there's just not going to be enough home health aides to meet the needs, just because the baby boomers are, I mean, that pig in the python they talk about with the population is
Yeah.
is just starting to turn 80 or 85. So the needs are going to continue to go up probably for the next 20 years. So we're going to have to get creative in terms of how do you make the home as safe as possible, the technology give as much protection as possible, and then augment with an actual real person. Who knows, maybe a robot, but I think there are ways to do it. We just have to think differently.
So it's a great segue into, I'm certainly not suggesting that you're about done, but you're definitely in the later stages of your career. So
Yes.
what's in the future with the time that you have left, with your goals as in your career?
Good question. I've been thinking about that a lot. I've been thinking about that a lot for a couple of reasons. Very few of which have to do with my actual age, right? So I'm 58. I'm happy to report, and feel no older than well, I certainly feel a little older, but I'm running every day or every other day. So the age isn't part of it. I think for me, what had me start thinking about what do I want to do in my last career, if you will,
Yeah.
was both the pandemic, because that was a wake up call. And then as part of the pandemic, my mother, who was in the assisted living at the time, declined very quickly because of the social isolation, and died shortly thereafter. And it was, for me, it was like, okay, you hear people say life is short. Guess what it is? And
Yeah.
so what I'm thinking about is how can I double down on helping to make the world a better place, but maybe more focus to continue to have healthcare be a place where we're getting really good care. Clinicians, physical therapists, and others can do the work they love to do, not encumbered by documentation and so forth. And so some of that I can do here, but I fully expect that I'll probably look to work with several organizations. I've thought about a consultancy. Like, how do you take you've done incredible things in your career, Steve. How do you share that? How do you share that in a way that's not cost prohibitive to people?
Right.
That's really where I'm looking to start to pivot, because there are lots of much younger folks who are eager and excited and motivated. I still am, but they have a little bit more energy than I do. How do
Yeah.
you put a little wind in their sails? And so I'm thinking a lot about how I can do that, probably through at least my mid 70s. So I got 10 or 15 years left of at least that, I hope, of
Well,
good
you
work.
have such a wealth of knowledge and experience that you're right, that can be very helpful to others that are at different stages of their careers. And you don't want to be cost restrictive. On the other hand, I think people are willing to pay for that, and if they recognize it, it's like, the wisdom that you gain doing all the things you've done, and if it can, speed up the learning curve for somebody else, it just really makes a difference. So there's definitely a space out there for that, and I'm sure you'd be great at it. You mentioned too, about your mother. My wife will tell you that her mother was in an assisted living facility during COVID, and she said she didn't die from COVID, but she died because of COVID. Because same
Yep.
thing, she was very social and on the lockdowns and visiting and whatever, and if you cognitively you don't understand that,
Yep.
it's just horrible. So yeah, she experienced the same thing. So
Yeah. Well, tell her I send my regrets, and I know exactly how she feels. And it
yeah,
was, I'll never forget, because there was about a year of time that I couldn't see my mother. They hadn't, the window visits and stuff. The first time that I got to see her, she was gone. She was not the same person. I'll never forget. It was heartbreaking.
uh,
So like, and I had a conversation with the folks that were the staff at the senior living place. They were phenomenal, by the way. And I don't think that we've given them enough credit. I was saying to her, it was so difficult to see my mom decline like that. And she said, yeah, I'm sure it was. She goes, I had to watch everybody that happened. And I was like, oh, I didn't even think about how awful it was for them.
Yeah, it
Um,
takes special people to do that work.
it really does. So it taught me to be grateful for what I have, and then to just continue to get up in the morning excited, curious, and figure out, all right, how can I make a difference today?
Yeah, yeah, for sure. Well, Michael, in anticipation of our discussion today, what haven't I asked or what haven't we covered that you would like to get into the program?
I think maybe just the one of the things that I'm most proud about, we didn't really talk a whole lot about, though I've loved the discussion. An hour goes by really fast.
Yeah,
Is the emphasis on teams and team building,
yes,
and
yes,
why that is so important um, as the flux capacitor, if you will, to good organizations. And so you and I have chatted a bit about this in the past. Um, I think people underestimate how how important and how valuable it is to create a culture of curiosity, of challenge. Like, how do you make sure that your senior team is willing to say the things that need to be said in a way that's kind and understanding with a sense of urgency? And so all that teaming capacity, how you structure meetings, like the underpinnings, the unsexy underpinnings of running a good business, to me are really fascinating and don't get appreciated to the degree I think they should in many organizations.
yeah. I'm so glad you brought that up because as a podcast on leadership, you're singing my language right now. Teams are everything, and it's I think the best leaders are those that number one can build the best team, and number two, facilitate or lead the teams, and the people that are really good at that, I think, are the ones that are successful, and it's not something that you necessarily just know how to do. It's you learn from mentors, you learn from others, you make mistakes, you hopefully learn from those mistakes. But a well-oiled team that trusts each other and works well together is going to do so much better than any one individual or any small group of people. So I agree
Yeah.
for everything. So
The thing I would add to that is, and I know you did this as well, is the team needs to be able to function well when you're there and when you're not.
yeah,
And so one of the
absolutely.
things I'm most proud about is I have an amazing past tense had an amazing team that I worked with to run the home health practice. That team has been fully intact for over 7 years, and
Yeah,
they are doing great with the guy that we hired. And I've been very successful at staying out of the way. It's not been easy.
yeah, I
Uh,
bet.
but somebody always says, that your best measure of success is does what you built stick around and last after you've left? And we're almost a year into it, and the team is actually they're off. They're having their best year so far. Maybe it was just time to get me out of the way. Who knows?
Yeah, yeah.
But that takes, from a leader's perspective, that takes a level of maybe it's humility. I'm not sure what it is, but sometimes I'm thrilled that they're doing great, and sometimes I'm like I'm like I feel a little jealous or a little sad, but it's that's a measure of success in my mind.
Well, anyone who understands the system of leadership and what how to do that would look at that and say that's only because they were well trained, well put together. You prepared for the succession plan. You did it, and you walked away, and they didn't miss a beat and actually did better. That's a tribute to a great leader. I wouldn't. I know we all kind of get imposter syndrome. Sometimes you're kind of like, oh man, when they maybe didn't need me, but
Right.
they did well because of what you did setting that up. So I think you got to pat yourself on the back for that one.
No, thanks. Thanks. I'm proud of it for sure.
Michael, at this time in the interview, I always ask my guests the same common question, and that question is, in relation to leadership, what is a pearl of wisdom that you could leave us with today?
Um, I would say there's probably several, but I would boil it down to know yourself.
Mhm.
Spend some time and make sure you know yourself and be eyes wide open. I know myself really well. There are parts of myself I don't like to look at. And I don't mean physically, but sometimes I can be a little bit full of myself. So know yourself. One, be kind to yourself, right? And if you set those things up and take care of yourself, it isn't selfish, but you can only jump so high off of a foundation that's soft or a foundation that's well developed and firm. And so, right, know yourself, be kind to yourself, take care of yourself, and that becomes to me the foundation for taking better care of everybody else. which we sometimes forget. I'll take care of everybody else and get to myself later. That doesn't work. And so I think don't feel bad or guilty about it. It's actually the right thing to do.
Yeah, well said, well said. Well, Michael, this has been a real pleasure. We don't know each other super well, but I have always respected you from afar, and the interactions I have had with you have been fantastic. And I was really excited to get you on the program today. And I learned a lot, in this geriatric population that isn't my, go-to or isn't as much as I know about. I certainly learned a lot, and I think our listeners will as well. So keep doing what you're doing. It sounds like you're doing fantastic things, and you're with an organization that really cares, and that's important. So thanks for being on the show today.
Yeah, my pleasure. Thanks again for having me.
Okay, take care, Michael. I know we'll run into each other down the road one of these days. So
Look forward to it.
take care. Bye bye. Thank you for listening to another episode of Profiles in Leadership. To listen to all my interviews, subscribe to Profiles in Leadership with Steve Anderson on Apple Podcasts, iTunes, and many other popular podcast platforms. Some of these interviews are on video, and you can search YouTube for Profiles in Leadership with Steve Anderson. You can also access the entire library of interviews on my website, orange.coaching.com, and that is orangetheword.coaching.com, and go to the Media Center and click on Podcasts or Video Gallery. You can also enter the website from pilpodcast.com.